PSRS, proximal splenorenal shunt for portal biliopathy. A 38-year female, known case of EHPVO for last 17 to 18 years with a history of hematemesis in past and already underwent multiple sessions of endotherapy. Presented with itching, pain and fever. On investigations found to have altered LFT and CBC, the bilirubin was 7.5. The OTBT were marginally elevated with the elevated alkaline phosphatase. Her HB was 9.7. Total count was 3,540 and the platelets were only 52,000 because of the hypersplenism. She was further investigated with the CT scan and MRCP to look for the biliary anatomy. So MRCP picture was little horrifying with a tight stricture near the confluence, and it was completely obliterating, creating it almost type 1 portal biliopathy. The CT confirmed the huge and gross amount of collaterals with a large splenomegaly, and luckily there was a good splenic vein which was available for the future surgery. CT photography was done to look for any abnormal vessels and collaterals. PSRS is indicated as a first stage surgical treatment for the patient with a symptomatic portal biliopathy due to EHPVO, or maybe a non-cirrhotic portal fibrosis or NCPF related portal hypertension. Whenever biliary drainage is needed but endoscopic stenting is either failed or it is not feasible in view of multiple collaterals, then that is probably the time that PSRS is done, and it aims to decompress the portal system and diverts the pressure to the systemic circulation. So this is the diagrammatic representation how the PSRS is done. So a particular patient, that is the left subcostal incision that we have taken for this particular patient. Upon opening the abdomen, you could see there is a huge spleen with perisplenitis and large number of collaterals. The splenic artery identified and was ligated in continuity. You could see the large amount of collaterals in the diaphragmatic and posterior retroperitoneal area. Luckily, we had very less collaterals in the abdominal cavity. So splenectomy is done in a very standard way. However, the careful dissection is done with the preservation of both the polar veins, because the polar veins were quite big in size. The main splenic vein was around 20, so we decided to sacrifice the main splenic vein. But we preserved the polar veins, and retroperitoneal dissection is done to identify and partially apply the clamp on the left renal vein. And finally, once both veins are aligned, we can see that the Cooley's clamp is applied on the renal vein with a sling on the proximal side, and a bulldog clamp is applied on the inferior polar vein of the spleen. And the anastomosis is done with the help of 6-0-proline. One can see that once the corner suture is taken on one end, the gradually continuous fashion anastomosis is further advanced. We are doing this anastomosis with microscope we have in our theater, so it's pretty precise and it's almost around 8 to 10x magnification, so it's very neat and clean. One can say that you can do a pretty good vascular anastomosis if you have a good quality magnification. So careful suturing is progressed and the posterior layer is continuous, and 6-0-proline is used with a double arm. You can see the equidistance placement of sutures that we are doing it, and the assistant is very important. He is carefully holding the surrounding pancreatic and colonic tissue. So steady and clear field is very much needed to do this variety of anastomosis, especially vein to vein, which is very friable in nature. And one can see now that the posterior layer anastomosis is almost complete. The posterior corner is now secured and rubber shot is applied. Once the posterior layer is done, it's time to take the another arm of needle to continue with the anterior layer, and in similar fashion the anterior layer of anastomosis is also carried out. In our practice, we try and give around 3 to 5,000 units of heparin before applying clamp on renal vein. and all the saline that is used for irrigation or wash is always heparinized saline. So it's helpful in prevention of the immediate I mean coagulation or thrombus within the shunt, because it's a venous system, it's a relatively low pressure system, so that helps in immediate thrombus formation near the sutures of the shunt. Particular case, when we open, we try and measure the portal pressure. The portal pressure for the particular case was somewhere around 35, and once we finish the shunt procedure, we always try and measure the pressure again. And this case, the portal pressure had fallen down to somewhere around 11. So we were happy with the procedure. So this is how, once the shunt is done, we release the proximal part bulldog to take off any air within, and the final suture is placed and the knot is tied. We try and excise a part of you can say rhythm vein in order to accommodate the dilated shunt. So a growth factor is left behind, and then finally the one end of the sutures are tied down. So aim is to do a patent good around 8 to 9 mm size, or maybe around 10 mm size uh, shunt. So we found that probably we required a couple of sutures at the corners. So the proximal area of the corner, a figure of 8 one suture is taken, and that has been now tightened, and we release the proximal clamp. We have still applied the renal vein side, so we could see that yes, there is a significant decrease in the leakage of blood, so that particular corner is secured, but we could still see that there is a blood seeping out from the proximal end. Here we don't now just tie it, but before we tie, we will release the clamp so that further growth is given. The growth factor is completely given, and then in the last, with the small oozing or bleeding which is happening, we allow it to happen, and once the bleeding is ongoing, one can see that the shunt has completely expanded. Only that's the time that you try and apply a knot over there at the suture so that the bleeding stops. So one can see that completely swollen and nicely opened up shunt is there. So the last suture is usually tightened on a little bit of oozing or bleeding that we allow to happen. And once it is done, we try and pack it with the help of dry gauze piece, wait for 5 to 7 minutes, and then we see that the entire area is completely dry. You can see the nice completely opened up shunt around 9 mm in size. The patient was discharged on day 4 following the surgery. No blood were transfused during the or after the surgery. The counts has improved, as well as the LFT got also improved on day 4 following the surgery. Thank you so much.